Imagine walking into a doctor's office. You've waited forever, you feel awful, and the doctor's just, staring at a screen. They ask a few questions. Type, and then just hand you a prescription. You feel less like a person and more like, I don't know, a data point.
It's the clerk mentality. Yeah. Just filling in the fields. Name, age, symptom, done. Next patient.
Exactly. And what we're looking at today, it's this postgraduate guide for ENT specialists, that's ear, nose, and throat doctors. It argues that this clerk mentality isn't just annoying, it's actually dangerous.
It is. The guide's whole argument is about shifting from simple data gathering to what it calls clinical reasoning.
And that phrase, clinical reasoning, that's really the heart of our deep dive today, isn't it?
It is. It's a total mindset shift. The source is essentially a training manual for diagnostic interrogation. It's telling young doctors, stop just writing things down. Start building a 3D model of the disease in your head while the patient is still talking.
It's basically a guide on how to be a medical detective. And we're going to break down the wrong way versus the right way to interview a patient. And to make this feel real, we're going to follow the case of a patient from the guide, a man named Mr. Anwar Ali.
And, I should say, Mr. Ali's case is pretty heavy, but it perfectly illustrates the point. If you ask the wrong questions, he gets some throat lozenges.
Right.
If you ask the right questions, using that clinical reasoning, you realize he's in the fight of his life.
So let's start where every appointment does. The boring stuff, the biodata, name, age, occupation.
Right, the stuff that seems like filler.
Yeah, but this guide says for an ENT, this is where the diagnosis actually begins.
Oh, deeply. Take occupation. The lazy way, the clerk way, is to just ask, what do you do? The patient says, I'm a carpenter, and you write it down and move on.
Which, that seems fine. He works with his hands.
But it has zero clinical value if you stop there. The guide says the right way is to follow up immediately. Are you exposed to wood dust, chemicals, metal fumes? What's the ventilation like? You're not interested in the job title, you're interested in the exposures.
That wood dust thing really jumped out at me. I know sawdust is annoying, it gets everywhere, but the guide links it to something incredibly specific, sinonasal adenocarcinoma.
It does. It's a very aggressive cancer in the nasal cavity, and the biology is, well, it's grim. Hardwood dust particles are the perfect size to get trapped in the mucus of the nose.
So they don't get blown out or swallowed.
Exactly, they just sit there. And over years, that dust creates chronic inflammation, it stops the natural cleaning cycle of the nose, and eventually it can mutate the cells.
So if you just write down carpenter, and you don't immediately think adenocarcinoma, you could be missing a huge red flag.
You're missing the why, and clinical reasoning is all about the why. You're identifying a high-risk person before you even examine them.
Okay, so let's get to the main event. The chief complaint. Mr. Ali comes in and says, Doc, my throat hurts. The amateur move is to ask, how bad is it?
A totally wasted question. Bad is subjective. It doesn't help me solve the puzzle. The guide says you have to distinguish between two very different sensations. You have to ask, is it pain when you swallow, or is it a feeling of something being stuck?
This is the odonophagia versus dysphagia distinction. I love how these medical terms sound like Greek gods.
They usually are Greek, but yeah, the distinction is vital. Odonophagia is pure pain. It suggests inflammation, an ulcer, maybe an infection. It's that ouch, that burns feeling.
And dysphagia.
It's purely mechanical. It means the pipe is blocked. I'm swallowing, but the food isn't going anywhere.
So if a patient says it hurts to swallow, and the doctor just writes down difficulty swallowing, they've basically confused a fire with a barricade.
That is a perfect analogy. And for Mr. Ali, our patient, this is the first huge clue.
Okay, so this leads to the next part of the guide, which I thought was fascinating. Investigating the complaint. The right way to dig deeper is to ask if the trouble is with solids or with liquids.
This is one of those questions that really separates the experts from the novices. So if a patient tells you, I can't eat bread or meat, but I can drink water just fine, what does that immediately tell you?
Logically. Well, if water gets through, the pipe isn't totally blocked, but bigger things are getting caught.
Exactly. It points directly to a mechanical obstruction. A tumor is literally blocking the road, the big stuff gets stuck, the fluid trickles past it. That's a classic sign in throat or esophageal cancers.
But what if it's the other way around? What if they say, I choke on water, but I can handle mashed potatoes?
That's usually neurological. Swallowing liquid requires incredible speed and nerve coordination to close off your windpipe. If those nerves are damaged, from a stroke for instance, you'll choke on the fast-moving water. But a semi-solid like mashed potatoes moves slower, which gives your sluggish nerves time to react.
That is such a cool diagnostic pivot point. So, I can't eat steak, points to a tumor. I choke on water, points to the brain.
Broadly speaking, yeah. And now look at Mr. Ali. His problem started with roti bread a couple of months ago. Now he can barely handle biscuits.
So the blockage is getting worse.
The road is getting narrower.
There's another symptom description in here that I have to bring up because it's so vivid. The guide says, don't just ask, is your voice okay? You have to listen for a hot potato voice.
It's a classic term. It sounds funny, I know, but clinically, it's a massive alarm bell.
I can instantly hear what that sounds like. It's not just being hoarse, is it?
No, not at all. Hoarseness is usually about the vocal cords themselves being irritated.
Yeah.
A hot potato voice is different. Imagine you literally have a mouthful of scalding hot food.
Yeah.
You arch your tongue, you open the back of your throat, and you talk. Kinda like this. It's muffled, thick.
And clinically, that sound doesn't mean burn, it means blockage.
It means there is a space-occupying lesion. There's a mass in the back of the throat that is physically damping the sound waves. You can actually hear the tumor before you even see it.
Okay, so we have a patient with this muffled voice, can't eat solids, but then the guy takes this left turn that feels like a magic trick. It says one of the most important questions might be about his ears.
Yes. Refer to Telja. This is my favorite bit of ENT anatomy because it just shows how messy our evolution is.
The guide is so clear. The right way to investigate a throat problem is to ask, does your ear hurt? In Mr. Ali's case, he has sharp throat pain that shoots right up into both ears.
And here's the kicker. If you looked in his ears with an otoscope, they look perfectly healthy.
Which is the trap.
The ultimate trap. If a doctor looks in the ear, sees nothing, and sends the patient home with eardrops, they've potentially signed a death warrant.
Okay, so unpack the why for us. Why is his ear screaming if his throat is the problem?
It's a case of crossed wires in the body's electrical system. The throat is supplied by two main nerves, the glossopharyngeal, which is cranial nerve 9, and the vagus, which is cranial nerve 10.
Okay, nerve 9 and nerve 10.
But these nerves are multitaskers. Nerve 9 has a tiny branch called Jacobson's nerve that goes to the middle ear, and nerve 10 has a branch called Arnold's nerve that goes to the ear canal.
So the throat and the ear are on the same circuit breaker.
Exactly. So a tumor grows in the throat and presses on nerve 9. The nerve screams pain, the signal shoots to the brain. But the brain, in a moment of confusion, looks at the signal and says, well, hang on, this wire also connects to the ear, so the ear must be hurting.
That is just wild. The brain is basically misreading the caller ID.
Constantly. We see patients who've been treating ear infections for months, with drops, with heating pads, you name it, while a cancer is growing unchecked in their throat. That's why the guide is so insistent. If an adult's ear hurts but looks normal, you must check the throat.
It's back to that detective theme. You can't just trust the victim's statement. The ear says, I'm hurt, but the ear is, well, it's confused.
You have to trace the wire back to the source.
Speaking of sources, we have to talk about risk factors. The guide is brutal on this. It says you can't just ask, do you smoke?
That's a yes-no question. It tells you nothing about the volume of the damage. You need to calculate pack years. How many packs a day multiplied by how many years? It turns risk into a number.
But it gets even more specific with chewing tobacco, or gutka.
Right. And for listeners, gutka is a mix of betel nut, tobacco, and other chemicals. It's highly carcinogenic. And because it's chewed, the questions the guide suggests are, well, they're uncomfortably specific.
It's not just do you chew, it's do you keep the quid in one specific side of your cheek.
And do you sleep with it in your mouth?
That one made me shudder. Why is sleeping with it so much worse?
It's about contact time. When you're awake, you swallow, saliva washes things away. But if you sleep with tobacco in your mouth, you are essentially marinating your cheek in concentrated poison for 8 hours straight, with very little saliva flow. The risk just skyrockets.
And what about Mr. Ali?
He's used a gutka for 25 years, and he always keeps it in the right buccal sulcus. That's the cheek pouch on his right side.
So as a detective, you know exactly where to look for the evidence. You expect the tumor to be on the right side.
It's almost a guarantee. The geography of the habit dictates the geography of the disease.
So we built this whole profile of Mr. Ali. 63, rickshaw driver, can't eat solids, ear pain, hot potato voice, heavy gutka user on the right side. But there's one number in his chart that just stops everything cold, his weight.
The weight loss is the most terrifying statistic here.
He went from 63 kilograms down to 43 kilograms.
That's a 20-kilo drop. It's 44 pounds in just 2 months.
That's staggering. I mean, that's not just skipping a few meals because your throat hurts.
No, that is something we call cachexia. It's fundamentally different from just starving. In starvation, your body tries to conserve energy. In cancer cachexia, the tumor is hijacking your metabolism. It's releasing chemicals that just break down your muscle and fat to fuel its own growth.
So the tumor is literally eating him from the inside out.
Yes. When the guide mentions his BMI is around 15, that's incredibly frail. That changes the entire management plan. You can't just operate on a patient like that. He wouldn't survive the anesthetic.
So Mr. Ali is sitting in front of you. He's 43 kilos. He's got the voice, the ear pain, everything. As the detective, you basically solved the case before you even run a test.
You have a very, very strong hypothesis. But now you need proof. You need to look.
The physical exam described in the source is pretty grim. Apart from the cachexia, they look for something called Moore's sign.
Laryngeal crepitus. It's a tactile test. So normally, if you take your own voice box, your Adam's apple, and you gently wiggle it side to side, you'll feel a little click or grating sound as the cartilage rubs against your spine. That's normal. That's good.
And with Mr. Ali,
If there's a tumor growing behind the voice box, it acts like a cushion. It pushes the larynx forward. The clicking sound disappears.
that is such a simple physical detail. The absence of a click tells you there's a mass in the way. So what's the gold standard for diagnosis here?
The guide calls for a triple endoscopy or panendoscopy done under general anesthesia.
Okay, why triple? If we're pretty sure the cancer is in his throat, why are we also looking at his lungs and his esophagus?
Because of a concept called field cancerization.
Field cancerization.
Think about it. All that gutka and cigarette smoke. It didn't just hit the one spot where the tumor grew. It bathed his entire upper aerodigestive tract, the mouth, throat, windpipe, food pipe for decades. All of those cells are unstable.
So you could fix the throat cancer, but completely miss a separate lung cancer that's already started.
Exactly. We call them synchronous primaries. There's a real risk of a second independent cancer starting in the lungs or esophagus at the same time. It would be a tragedy to cure his throat cancer, only to have him die 3 months later from a lung tumor you missed because you didn't look.
That is a level of thoroughness that borders on paranoia, but I absolutely see why it's necessary.
You have to survey the whole territory.
So based on all this, the source suggests he's likely stage 3 or squamous cell carcinoma. That sounds really advanced.
It is. Which brings us to management. And the guide emphasizes this needs a multidisciplinary team. You don't just rush to surgery.
Right, because of the weight, he's starving.
You have to treat the patient, not just the tumor. The first step is what we call optimization. He needs a feeding tube, either down his nose or directly into his stomach. We have to build his strength up before his body can even handle treatment.
And once he's stronger, what are the options?
It's a major crossroads. Option A is organ preservation. That means chemoradiotherapy, trying to kill the cancer while keeping his voice box and throat intact.
But the guide suggests that if the cartilage is destroyed, like that missing click we talked about, that might not be an option,
Correct. If the cancer's too aggressive or the structure is compromised, you have to go to option B surgery, a total laryngectomy.
which means removing his voice box.
Completely. Removing the voice box and probably part of the pharynx. It's a massive operation. He'll breathe through a hole in his neck, a stoma, for the rest of his life, and he'll lose his natural voice.
The source mentions something incredible about the reconstruction, though. If you take out that much tissue, it mentions using a pectoralis major myocutaneous flap.
This is where surgery becomes like biological engineering. You have a huge hole in the throat. You can't just leave it open. The carotid artery is right there. So the surgeon will actually disconnect the pectoralis major muscle from the
The
chest.
pec muscle, like the bench press muscle.
That's the one. They rotate it up into the neck, keeping its blood supply attached, and literally use that chest muscle to build a new throat wall.
That is absolutely unbelievable. Taking a muscle designed to push a door open and using it to seal a neck.
It saves lives, but think about the cost. Mr. Ali loses his voice, his normal anatomy. It is a life-altering trade-off.
Which brings this entire thing back to the beginning, back to clinical reasoning.
Right, because if a doctor had caught this 6 months earlier, when it was just a little pain, before the weight loss, before the hot potato voice, the options would have been completely different.
He might have been a candidate for laser surgery, or just radiation. He might have kept his voice.
Exactly. The wrong way of asking questions, that vague, how are you feeling approach, it delays the diagnosis. And in cancer, time is tissue.
It really shows that diagnostics isn't just about knowledge, it's about strategy. The way you phrase a question can literally change the timeline of a disease.
The guide says it best. You are not gathering information, you are testing a hypothesis. Every question should be an arrow aimed at a specific possibility.
I want to leave everyone with one thought that's really sticking with me, and it goes back to that referred otalgia. You know, the pain in the ear that's actually coming from the throat. It's a powerful concept.
It just feels like a perfect metaphor for so many things in life. We spend so much energy fixing the thing that's screaming the loudest, the ear pain. Maybe that's a crisis at work, an argument with a partner, or just a feeling of anxiety.
When the actual problem, the pathology, is hidden somewhere else entirely.
Exactly. The ear is just the messenger. The throat is the real problem. Maybe the argument isn't about the dishes, it's about respect. Maybe the work crisis isn't about the deadline, it's about a broken process way upstream.
That's a very diagnostic way to look at the world. Don't just treat the screaming nerve. You have to trace the wiring back to the source.
Mr. Ali's case is a tragic masterclass, but it really makes you appreciate the detective work that goes into medicine. And it definitely makes me appreciate being able to just swallow a glass of water.
Right. That's it for this deep dive into the detective work of diagnostics. Stay curious, ask the right questions, and we'll catch you next time.
Goodbye, everyone.